So, with that being said, let's go ahead and start chapter 23. So we're going to be doing renal. Chapters 23 and 24 both are in relation to renal, kidneys, and how the kidneys operate in filtering out your blood. And then the last chapters that we're going to do are going to be sexual reproduction. We're going to start with male reproductive system, and then we're going to finish up the semester with female reproductive system. So, fun stuff. So I included some things that you guys aren't responsible for this class. When you guys get into pathology, you're going to have to know all the different types of kidney stones. So if it's like a calcium phosphate type kidney stone versus a staghorn type kidney stone, these kidney stones, thankfully, are pretty rare. Any idea as to what might be the underlying cause of a kidney stone that freaking big? That's huge. That's like within all the major and minor calyces, extending out even into like the hilum/renal pelvis. So it's pretty insane. What do you guys think might cause something like that? Not drinking enough water? That's a good theory. Dehydration and pH balance can definitely result in nephrolithiasis. So the technical term for a kidney stone is nephrolithiasis. The most common ones are ones that are based off calcium. These ones over here are made of magnesium ammonium phosphate. Now, these are going to be a result of reoccurring kidney infections, renal infections. There's a bunch of organisms that result in UTIs, urinary tract infections. The most common one is going to be E. coli, Escherichia coli. That's going to be the most common cause. But there's a lot of different bacteria that can cause UTIs. So one example would be Proteus mirabilis. Proteus mirabilis is what results in staghorn kidney stones. So these are really huge. What happens with these types of infections is that the pH levels of the urine start to get affected. So with these in particular, the pH goes up, so it becomes more alkalotic. Urine generally pH is a little bit more on the acidic side, so it's around like 6 in terms of pH. But with reoccurring infections due to Proteus mirabilis, that increases the pH. That increased pH basically starts bringing different types of like ions and solutes out of solution, and then you wind up with these massive kidney stones. They can go in there. Urologists can go in there. They can send like these ultrasonic frequencies that can help to kind of like break the stones down. But usually, if it's something like this, usually you're going to require some form of surgical intervention. So they'll have to either go in there, remove the stone surgically, or maybe they might have to go as far as to do like a kidney transplant. So I included this Radiopedia. If you go into Radiopedia, there's tons of really cool like CT scans, MRIs, and whatnot. So this is an example of one of these cool little CT scans that you can literally go in there and you can just play around with it, and you can see all the different structures, so you can move. This is like what you would do when you go into like the hospital setting and you look at a patient's charts. If they do like a CT scan, you can like literally go in there and see the image and go through every plane of dissection. So super cool. Look at the size of those kidney stones, absolutely massive. So that's one example of something that can happen to your kidneys. And we're going to talk about other issues throughout chapter 23 and 24, but I thought I'd include that as an opener because it's kind of interesting. But you're going to learn more about that when you get into pathology in the coming semesters. So this is what we're going to be doing throughout chapters 23 and 24. We're going to be looking at some of the gross anatomical structures that you need to be familiar with throughout the whole renal system. We're going to talk about how the kidneys function physiologically. So everything from filtration to reabsorption to secretion, all the way down at the level of the nephrons. So, and then when we get into reabsorption and secretion, we're also going to talk about osmolarity. So that's going to be for next time. And next time we're going to talk about the micturition reflex. Micturition is just a fancy word for urination. Okay, so if micturition is just peeing, nothing really too crazy there. So these are the gross anatomical features that you should be familiar with. So one thing to keep in mind about where the kidneys are located The kidneys are going to be retroperitoneal. Right? So they're going to be in the retroperitoneal cavity, effectively behind all the major organs of the abdomen. There's the main difference between the right and left kidney is going to be its location. The left kidney is going to be a little bit higher up than the right kidney. Now, the reason why that's the case is because the presence of the liver. The liver is a really, really large organ that's going to be sitting in the right upper quadrant. Because of the location of the liver, the right kidney is going to be located a little bit inferior in relation to the left kidney. The left kidney is going to be sitting beneath the spleen, which is much smaller than the liver. Going from the kidneys, you're going to have the hilum. The hilum is just basically a port through which you get vessels going through. For the kidney, you're going to have the ureters going through the hilum. You guys probably recall we talked about the hilum when we're talking about pulmonary system, right? The pulmonary system, that's where you had the bronchi entering into the lungs. You had the pulmonary arteries and pulmonary veins. The hilum of the kidney is kind of a similar concept. It's just basically an entryway into the organ. From the hilum and the renal pelvis, you're going to have the ureters. The ureters are going to be the channels through which urine is able to travel until it gets stored in the bladder. And then from the bladder, you're going to have the urethra, and that's where you have the ultimate excretion of urine. Other thing to keep in mind about the location of the kidney is going to be located around the 12th thoracic vertebrae and the second lumbar vertebrae. And then in terms of the location of the ribs, the kidneys are going to be located adjacent to the 12th rib. Okay, so one clinically significant thing about the location of the kidney is if an individual has any sort of like damage or infection of the kidney, one thing that we usually do on physical exam, we do the Murphy's punch test. So you basically just put your hand against the patient's back, and then you gently tap against your own hand. You don't like punch them right there in the kidney, but you kind of put your hand there, gently tap it. If there's any tenderness, you can call that a positive Murphy's punch test, or you could say they have costovertebral angle tenderness. So let me show you what a video looks like of the physical exam. One version, the other version, other patients tolerated, and then that final. So that's the Murphy's punch test. That's not to be confused with Murphy's sign. Murphy's sign is another test that can be done, but it's going to be testing for cholecystitis. So that's going to be inflammation of the gallbladder. So what you do with the Murphy sign is you're basically digging your fingers like directly beneath their ribs. Then you're having the patient inhale. As they inhale, it pushes the liver down. And then it's going to basically push the gallbladder against your fingers. And so if they start wincing and they elicit some sort of like pain from that, that would be a positive Murphy sign. So a little bit of a different test. Same name for a different thing. As a matter of fact, one of my supervisors, when I was doing my rotations, I was like, oh, the patient had like a negative Murphy sign. He looked at me funny. He's like, what the hell are you talking about? I was like, yeah, I was testing his kidneys. He's like, that's not what it's called. He said it was costovertebral angle tenderness. I was like, no, it's called a Murphy sign, because he was thinking it was the other Murphy sign. So there's two different Murphy's tests. So if any of your supervisors in the hospital setting gives you any crap for that, just tell them that there's two different Murphy's tests. So this one's the Murphy's punch test. Cool. So excretory system organs. Okay, so some of the major organs are going to be the skin, right? So the integumentary system, that's going to be where you can secrete different types of wastes through your glands. When you're breathing, you're also going to be releasing different wastes, right? Carbon dioxide being one of the most important ones. You're going to be obviously releasing a lot of things into your GI tract, as we discussed over the last section. And then the urinary system. The main organs of the urinary system are going to be the kidneys, ureter, bladder, and the urethra. Okay? So we're going to go into, most of our focus is going to be on the kidneys themselves. So what do the kidneys do? Obviously, they're going to be responsible for the release of water, right? So maintaining fluid balance is going to be one of the major roles of the kidney. Another thing that's going to be associated with that is maintaining osmolarity. So we're going to talk about osmolarity a little bit later. Part of osmolarity is going to be involving different types of ions, right? So if you're dehydrated, you're going to be releasing less sodium because you don't want to excrete as much water through urination. So you can use your ions to be able to maintain osmolarity and proper fluid balance. Obviously, another thing is going to be elimination of waste. So whenever you have protein metabolism, you're going to get nitrogenous waste as a consequence. So whenever you're metabolizing protein, those nitrogenous wastes are going to predominantly be excreted through urine. And of course, you're also going to be excreting other types of foreign compounds as well that your body is not able to properly metabolize. pH balance is mostly going to be dictated by both hydrogen as well as bicarbonate. We're going to talk about a little bit later. And revisiting some of our hormones, we're going to go back into the renin, angiotensin, aldosterone system. Now, do you guys remember when that system kicks into play? Why do we use the renin, angiotensin, aldosterone system? To increase your blood pressure, to increase your blood volume. So that's going to be a really important role with renin, and that's going to be the first step. It's going to be at the juxtaglomerular cells within the kidney. So we'll go into more detail about that. Erythropoietin. So you, whenever you're anemic, or if you have if you've moved to like a higher altitude and you are living in a place where the air is a lot thinner, it's not as rich in oxygen, erythropoietin is going to kick in so that you can develop more red blood cells as a consequence. And then we're going to talk a little bit later about the conversion of vitamin D. The vitamin D is going to be basically turning into its active form within the kidney. So we'll go into all of that later on. So these are all the major structures that you guys should be familiar with. So the kidney is going to be surrounded by a fibrous capsule. It's going to be a nice, thick, fibrous type of tissue that helps to protect the kidney. Beneath that is going to be the renal cortex. And then below the renal cortex is going to be the renal medulla. Within the renal medulla, that's where you find these little pyramids. So they're going to be little triangular shaped structures. We call those renal pyramids. In between each of those renal pyramids, they're going to be separated by renal columns. Within those renal columns, you're going to find a lot of different blood vessels. The blood vessels that are going to be leading towards the glomerulus. That's where filtration takes place. Those blood vessels are going to be coursing through those renal columns. Once blood gets filtered at the level of the glomerulus, and then you have all of your filtrate passing through all the different tubules. You have your proximal convoluted tubules, loop of Henle, distal convoluted tubules. They're going to eventually lead into the collecting ducts. I'll show you an image of what that looks like in a moment. Those collecting ducts eventually bring all that filtrate and urine down towards the renal papilla. The renal papilla is going to be this little kind of cone-shaped structure at the very distal end of the renal pyramid, bless you, and that's where urine finally enters into the minor and major calyces. The minor calyces are going to be little tiny ones over here that help to collect the urine from the renal papilla. Those eventually drain into the major calyces. The major calyces eventually drain into the renal pelvis, which is going to be this region right here, and then urine eventually makes its way down into the ureter, where it can eventually wind up down into the bladder before it's ultimately excreted. So we went over all these structures. So renal cortex, that's going to be this region right over here. That's going to be the outer layer of the kidney. Renal medulla is going to be directly deep to that. So that's where you find renal pyramids, renal columns, and then eventually you wind up at the renal papilla, which leads into the minor calyces, major calyces, renal pelvis / hilum, going all the way down into the ureter. So let's talk about the different layers on the outside. So we talked about the fibrous renal capsule. That's going to be this structure over here that surrounds the kidney to help protect it. You're also going to have a lot of adipose. So remember how I mentioned that the kidney is a retroperitoneal organ. In the retroperitoneum, there's going to be a lot of fat in that area. And all that fat is basically going to help to protect the kidneys from any sort of injuries. Right? The kidney is a very important organ. You don't want to damage it, but it's also pretty vulnerable. Because it's pretty close to the flanks. So if a lot of my students in my medical physiology lab, they talk about like boxing injuries. Right? That's a common thing, right? Sometimes like people that are in MMA or boxing, sometimes you might get injured, get hit in the kidney. If you do get that type of injury, oftentimes it will result in hematuria, which is blood in the urine. Generally speaking, that kind of resolves on its own. It takes about like 2 or so weeks for you to get back to normal. But the reason why you have all that fat around the organ, all that fat basically just acts as an insulator to help protect the kidney from any sort of blunt injury. And then you also have the renal fascia, which is going to be a bunch of connective tissue that helps to anchor the kidneys in place. There are certain things that can affect the adipose tissues. So individuals who are basically like starving, or they're maybe doing like some sort of like crash diet, one thing that can happen is that the adipose around the kidneys start to deteriorate, right? Because they're going through a diet. So they're going to lose a lot of that fat, and because of that, sometimes the kidneys start to droop a little bit. So you get like renal ptosis, which is the kidneys will start moving a little bit inferiorly because they're no longer able to like remain set in place, surrounded by fat. So we already kind of talked about the hilum, but the hilum is going to be the entry point for several different structures. It's going to be where you have the ureters coming off of the kidney. That's also where you find the renal artery and renal nerves. And then the renal vein too. Renal sinuses. So this is not like terribly important, but renal sinuses are going to be these little tiny openings on the outside of the kidney. They're going to be surrounded by that renal capsule, but they're just basically going to be like these little cavitations that are found within the kidney. It's kind of low yield, not super important, but just know that that's what these little guys are. They're renal sinuses. And then the renal cortex, let's go into that again in a little bit more detail. That's where you're going to find the presence of the glomerulus. That's where you're going to find the proximal convoluted tubules, as well as the distal convoluted tubules, and a little portion of the loop of Henle. It's like the very proximal regions of the loop of Henle. The loop of Henle is going to be dipping into the renal medulla, but you're going to find all the other tubules over there. So the glomerulus and the different the proximal and distal convoluted tubules. Okay, we already went over all of that, the renal pyramids, etc. Moving on. In terms of the renal pyramids are kind of interesting. There's a lot of variation in the number of the renal pyramids. Renal pyramids is where you have like the concentration of urine taking place, and that's also where you find those collecting ducts that eventually you have several distal convoluted tubules draining into those collecting ducts. Some animals have a very, very rudimentary renal pyramid. Bless you. A good example would be, for instance, cats. We do a cat dissection in one of my labs. One thing that we look at is the cat kidney. The cat kidney basically just has one giant renal pyramid. It's very, very rudimentary. One thing that happens to cats quite often is cats often get like renal infections, and quite often that's going to be also a cause of mortality for cats, are going to be these like renal failure, renal function issues. For us, we have a lot more of these renal pyramids. We're going to have around 6 to 18, depending on the individual. And then the renal columns, that's going to be where you see different vessels that eventually lead towards the glomerulus and the renal cortex. And those renal columns are each going to subdivide those renal pyramids. And then renal papilla, we already talked about that, but that's going to be where you have urine being excreted from those collecting ducts, eventually arriving in both the minor and then major calyces. And then the renal pelvis, we already talked about that, but that's going to be what drains all the urine, eventually leading down into the ureter. Cool. So That's some of the major gross anatomical features that you guys should be familiar with. So let's start getting into what you see at the cellular level. So when you start getting into some of the little vessels and then leading down into the capillary beds, which are going to surround all the different tubules, as well as the loop of Henle, which will eventually drain into those collecting ducts. So don't worry about all these different arteries over here. Just keep in mind as the arteries get smaller. These are the ones that you're going to be more responsible for. So afferent arterioles, afferent starts with A. A is the first letter of the alphabet. That's what's going to lead into the kidney at the level of the glomerulus. At the level of the glomerulus, you're going to have all these different little tiny capillaries. They're all going to be fenestrated capillaries. That's where you have filtration taking place. That's where nitrogenous waste, that's where sometimes even a little bit of glucose might come out. That's where you get all of your solutes like sodium, things like that, all filtering out into the glomerular capsule. And then from there, you have the filtrate entering into the proximal convoluted tubules. That's these guys over here. Now, that's at the glomerulus. Then as blood is leaving the glomerulus, it's going to be entering into the efferent arterioles. Efferent, think E for exit. Okay, that's going to be the exit point of blood from the glomerulus. And then eventually it's going to make its way into the peritubular capillaries and then over to the venule system. The peritubular capillaries, that's all these capillaries over here that surround the proximal and distal convoluted tubules, as well as the loop of Henle. So those are going to be peritubular capillaries adjacent to all those different tubules. And this is where you're going to see secretion and reabsorption. So you have reabsorption of solutes and different things back into the blood, and then you have secretion of things from the blood back into the urine. And so we're going to go into all those details momentarily, but that's all going to be at the level of the renal cortex. So when we talk about these structures, the umbrella term for all these structures is the nephron. Okay, so if you ever heard the term nephrology, a nephrologist, that's a doctor that basically works with kidneys and treating patients that have any sort of like renal issues. And so nephrons are going to be the entirety of the glomerulus, the different convoluted tubules, the loop of Henle, as well as all of the blood vessels associated with those different regions. Oh yeah, and then keep in mind, your kidney is filtering a lot of urine at the level of the glomerulus. A lot of it gets reabsorbed, so you're not like constantly having to go pee, right? So if you weren't able to reabsorb all that filtrate, you'd be producing way too much urine. So you are producing a lot of urine because you have a lot of these nephrons, so about 1 million nephrons per kidney. So in terms of the structures of the nephron, we're going to talk about the structures as well as the histological cell types for each of these structures, because they're all going to be pretty important. The renal corpuscle is going to be this region that effectively surrounds the glomerulus. The glomerulus is going to be all of those little fenestrated capillaries within the renal corpuscle. Then you're also going to have the corpuscular space. That's where the filtrate of urine is filtering out of the nephron, or sorry, the fenestrated capillaries. Then as you move from the corpuscular space, urine is eventually going to make its way into the proximal convoluted tubules. Within the proximal convoluted tubules, you're going to see a ton of these little tiny microvilli, right? Remember when you see microvilli, we talked about that when we were discussing GI. You see microvilli when you see absorption of things, right? And so in the proximal convoluted tubules, that's where you see the most amount of reabsorption. And so within those tubes, you're going to see lots of microvilli so you can absorb more water into those regions. Then as you move further down, you're going to get down into the loop of Henle, which descends into the renal medulla. And then back up again, it's going to be leading into the distal convoluted tubules, which eventually leads to the collecting ducts. In the collecting ducts, you have multiple different entry points where it's basically collecting urine from several different nephrons and several different distal convoluted tubules. Okay, so in terms of what's taking place at each of these levels, the renal corpuscle is going to be where you have filtration. So filtration is going to be the very first step. That's where blood is going to be entering into the glomerulus. It's going to get pushed out of the glomerulus through those fenestrated capillaries. Okay, fenestrated. Remember, fenetra is French for window. You're going to have like all these little windows in those capillaries. Then, when you get into the renal tubules, you're going to have the proximal and the distal convoluted tubules. At the level of the proximal convoluted tubules, right over here, that's where you get a lot of reabsorption of solutes. The loop of Henle, you're also going to get reabsorption, but then when you get to the distal convoluted tubules, you're going to see mostly secretion taking place over there. And then the collecting ducts, nothing really happens at the collecting ducts aside from collecting urine and filtrates from several different convoluted tubules. Here's a little video that kind of talks about the dynamics of the glomerulus. So. We're going to talk about all those structures in greater detail a little bit later. So, super riveting video. So let's talk about some of the cell types in these different structures. So at the level of the glomerulus, that's where you're going to see fenestrated capillaries. So you have these little openings within the capillaries. They're going to be surrounded by podocytes, which we're going to talk about a little bit later. The capsular, the actual capsule itself, the glomerular capsule is going to be made up of squamous cell epithelial type cells. And squamous cells, that's what you find on like skin, for example. You're going to find a lot of squamous cells in regions where you don't want like fluids to be able to permeate through. Okay, so in other words, you want to help contain and confine the filtrate within the capsular space. So that's why you have a lot of squamous cells in that region. Now, as you move a little bit further down, so when you get into those proximal convoluted tubules, remember you have a lot of reabsorption. That's what's taking place at the proximal convoluted tubules. Because of the need for reabsorption, that's why you have all these little microvilli. Okay, so you have all these little tiny finger-like projections. It maximizes the amount of surface area, so you get a lot of reabsorption at these different levels. Then as you move further down, you're going to have different cell types, like cuboidal cells, for example. And then as you move up, you're going to have a little bit of reabsorption, but it's mostly going to be secretion at the level of the distal convoluted tubules. You have a few microvilli, but definitely nowhere near as much as you have in those proximal convoluted tubules. And as you get into the collecting ducts, you do have some secretion. You have a little bit of reabsorption taking place. So you will find cells that do have microvilli on them, but definitely not as much as the proximal convoluted tubules. So this is what's going on here with the different vessels. So you have your afferent arterioles. That's going to be bringing blood into the glomerulus, right? A is for afferent, is where you start, right? And so you get blood entering into the glomerulus. And as blood enters into the glomerulus, blood pressure is what's going to dictate how much filtrate is actually going to be coming out of the blood and into the capsular space. Okay, so we're going to talk about the fluid dynamics a little bit later. Then as blood leaves the glomerulus, it's going to enter into the efferent arterioles. And then urine is going to thereby enter into the proximal convoluted tubules. As you can see in this image, there's lots of microvilli. At the distal convoluted tubules, you're going to have those distal convoluted tubules coming into contact with the juxtaglomerular cells. And this is going to help to indicate whether or not the blood pressure is really high within the kidney or if it's really low. This is also the region where you're going to see renin being secreted, right? So this is a detection system to tell your body if you have like too few fluids or too much in terms of fluid levels. And so those are going to be really important structures that we're going to talk about in more detail later. So this is what an image would look like on a light microscopy slide. These are going to be your distal convoluted tubules. Your proximal convoluted tubules, you can barely even see through the lumen, right? You can't see through the lumen because there's all these little microvilli in there. So it's kind of taking up a lot of the space, and so you won't be able to see right through it. If you were to see through it, you would be thinking that those are distal convoluted tubules because there's really not much in terms of microvilli. This whole region right here is going to be the glomerulus. Right? That's where you see all those fenestrated capillaries. And you have the capsular space surrounded by the squamous epithelium of the renal corpuscle. That's on light microscopy. So this is what's going on throughout the entirety of your nephron. So starting from the glomerulus, that's where you have filtration taking place. And filtration is going to be dictated by the amount of pressure inside that glomerulus. And so if the pressure is really high, you're going to get a lot of filtrate getting pushed out of the blood and into the capsular space. So you're going to have filtration of urine from blood into the urine. Then reabsorption, which is what you see mostly taking place here at the proximal convoluted tubules, that's going to be going from urine back into the blood, right? Because you have these peritubular capillaries that basically run adjacent to the entire tubule system. And then secretion at the end is going to be where you have blood secreting contents back into the urine again. So you could calculate that out using a simple equation. It would just be filtration minus the reabsorption plus the amount of secretion, and that would give you the totality of excretion from your kidneys. So here's another breakdown of what that looks like. At the glomerulus, no, the glomerulus is filtration only. That's all that's taking place at the glomerulus. Then as you get into the proximal convoluted tubules, that's where you get a little bit of reabsorption, and then, or mostly reabsorption. And then at the distal convoluted tubules, you're getting mostly secretion at that point. And then make sure that you know the steps, right? So you start off with the renal corpuscle, the glomerulus. Eventually, it's going to be collected into the different calyces. Okay, collecting ducts over here will eventually lead into the minor and major calyces. Minor and major calyces eventually lead into the renal pelvis, leads into the ureter, bladder, urethra, and then at the end, the toilet. So, filtration, like I mentioned, only takes place at the level of the glomerulus. It's going to be dictated by blood pressure, but there's also going to be other things that kind of play into that. We're going to talk about the different types of oncotic pressures that kind of help determine which way the filtrate is going to be moving. One of those is going to be albumin. Albumin is going to be trapped within the blood. Albumin is too big of a molecule for it to be able to squeeze through the fenestrations in those capillary beds. But you do see cases where a person might have proteinuria. So proteinuria, which means that you have excessive amount of proteins in your urine, that's going to be indicative of a person that's undergoing some sort of like renal damage. So patients with like renal failure, for example, maybe stage 4 renal failure, goes all the way to stage 5, they might start getting proteinuria in their urine. For us guys that are in here, if you've ever used the restroom and the person didn't flush before you and you saw it was all really frothy type urine, that frothiness is going to be indicative of proteins in the urine. So that's one thing that you can see if you just look at someone's urine and super frothy, they have proteinuria. So ideally, you're not supposed to have any proteins whatsoever in the urine. So this is what the glomerulus looks like. This is going to be on electron light microscopy. Scanning electron microscopy. So you can see all those different little capillaries. And there's also going to be there are also going to be a bunch of little podocytes that surround each of those capillaries that can kind of help to control the movement of the filtrate into the capsular space. One thing to keep in mind about the vessels that are leading in to the glomerulus are going to be much wider. So the afferents are going to be very large. As you get into the efferents are going to be much more narrow than the afferents. Okay, moving on. And this is FYI. I'm not going to make you guys calculate the clearance of different substances, but I included this in here because it's kind of interesting. You can calculate the clearance of different substances to help you gauge what's going on at the level of the nephron. So if you were to calculate the clearance of inulin, that's just a very simple compound that gets completely filtered out of the glomerulus. It does not get reabsorbed, nor does it get secreted. So in other words, you're able to completely measure the amount of fluid that's coming out of the glomerulus. So that gives you the glomerular filtration rate, i.e. the GFR. Now I included this image over here on this little chart because it kind of helps you kind of gauge where a person's at in terms of renal failure. We measure renal failure by their ultimate glomerular filtration rate. The less they're able to filter out of their kidney, the further along they are in renal failure. So stage 3 is pretty severe. Stage 4 is very severe. That's going to be like almost total loss of renal function. And then stage 5 is going to be just like complete renal failure. At stages 4 and at stage 5, those patients generally have to go on dialysis. And if you know anything about dialysis, it's not fun. It's a terrible, it's really bad for like the person's entire quality of life. When patients goes to dialysis, they're going to have to go there 3 times a week. Dialysis takes 4 hours per session. Generally, after they're done with their session, the patient is completely exhausted. So it's not a fun situation to be in. Some of the leading causes of renal failure: hypertension, untreated, long-standing hypertension, diabetes. So diabetes mellitus will cause renal failure. That's one of the more severe consequences of diabetes. But you can calculate the clearance of a lot of different things. You can calculate the clearance of PAH. You can calculate the clearance of glucose. Calculating the clearance of inulin would give you the rough estimate of the patient's glomerular filtration rate. Let's watch a little video on the GFR real quick here. It's not too loud.
Increases in afferent arterial resistance lead to decreases in glomerular capillary hydrostatic pressure. Let's use this animation to show what happens to glomerular capillary hydrostatic pressure, which is represented by the green line, as afferent arterial resistance increases, which is represented by the narrowing of the afferent arteriole. From this, we see that increases in afferent arterial resistance result in decreased glomerular capillary hydrostatic pressure. This occurs because the afferent arteriole is upstream of the glomerular capillaries. Conversely, increases in efferent arterial resistance lead to increased glomerular capillary hydrostatic pressure. Now, let's pay close attention to the glomerular capillary hydrostatic pressure as efferent resistance increases, which is represented by the narrowing of the efferent arteriole. The increase in hydrostatic pressure associated with the increased arterial resistance is due to decreased outward flow via the efferent arteriole. This occurs because the efferent arteriole is downstream of the glomerular capillaries, which creates a back pressure within the glomerular capillaries themselves. The net ultrafiltration pressure determines glomerular filtration, and that net ultrafiltration pressure equals the difference between net hydrostatic pressure and net oncotic pressure. Now let's use this animation to show how this occurs. Watch how increases in afferent arterial resistance, as seen by the narrowing of the arteriole, lead to decreases in glomerular hydrostatic pressure, as shown by the green line. As the net hydrostatic pressure decreases, we see a parallel decrease in net ultrafiltration pressure, or GFR, as shown by the blue arrow. We also see a minor increase in net oncotic pressure, as shown by the pink line, which contributes towards the further decrease in net ultrafiltration pressure, or GFR. Net oncotic pressure increases slightly because fluid in the glomerular capillaries has more time to be filtered, which concentrates the non-permeable solvents in the glomerular capillaries, thus increasing the net on-body pressure. Conversely, as efferent arterial resistance increases, as shown by the narrowing of the efferent arteriole, we see an increase in glomerular capillary hydrostatic pressure, followed by an initial increase in net ultrafiltration pressure, or GFR, which occurs because of the back pressure created within the glomerular capillaries. Notice that as the hydrostatic pressure continues with increased efferent arterial resistance, the net ultrafiltration pressure, or GFR, paradoxically decreases. This is because the net on-body pressure increases, which outpaces the increase in glomerular capillary hydrostatic pressure. This observation is clinically relevant because some drugs preferentially cause increases in afferent arterial resistance, which lead to decreased GFR. This can prove dangerous, especially in patients with compromised renal function. In conclusion, increases in afferent arterial pressure result in decreased glomerular capillary hydrostatic pressure, which leads to a decrease in renal plasma flow and a decrease in GFR, or net ultrafiltration pressure. Conversely, increases in efferent arterial resistance result in increased glomerular capillary hydrostatic pressure, which leads to a decrease in renal plasma flow and an initial increase in GFR, or ultrafiltration pressure. However, with increasing efferent arterial resistance, we see a paradoxical decrease in GFR, or net ultrafiltration pressure, which is due to the increase in net oncotic pressure, which is directly related to increases in the filtration fraction.
All right. Good stuff. Cool. So let's talk a little bit about the juxtaglomerular apparatus. So we touched on this before when we discussed the renin-angiotensin-aldosterone system. The juxtaglomerular cells are effectively going to be adjacent to the afferent and efferent arterioles that lead into and out of the glomerulus. So that's going to be the juxtaglomerular cells. The juxtaglomerular cells are going to also come into contact with the macula densa. The macula densa is what's going to be found at the distal convoluted tubule. The macula densa, so this is the distal convoluted tubule, that's where urine is going to be passing through. So blood pressure is going to be triggering the juxtaglomerular cells. The amount of urine is going to basically trigger the macula densa, okay, because that's going to be found within the distal convoluted tubules. The other hormone that's going to be associated with this region is going to be erythropoietin. So, renin and erythropoietin. Here's another image of what that looks like. So, here's your afferent arteriole, glomerulus, efferent arteriole. That's where you find the juxtaglomerular cells. So that's going to be responding to changes in blood pressure, for instance. And then at the level of the macula densa, that's going to be found at the distal convoluted tubules. So that's going to be affected by changes in fluid volume within the urine. So we're going to talk a little bit about that later on. So don't worry just yet if you feel like we're just skipping over that. A few things that are taking place at the level of the tubules. So remember, at the glomerulus, that's where you have filtration. At the tubules, that's where you have reabsorption and secretion. Sometimes you'll get a little bit of filtration of glucose. Now, as a person becomes more and more insulin resistant, or if their blood sugar is completely out of control, right? If they're like, uncontrolled diabetes, you're going to get a lot more glucose filtering out into Bowman's capsule. Okay, so that's something that you might see on a urine analysis. I'll include urine analysis towards the end of renal. I'm not going to test you on what you see on urine analysis, but one of the things that you look for on a urine analysis, where you like dip the little strips into the urine, they test for the presence of glucose. And so you can see if a person has really uncontrolled diabetes just by looking at that. So generally speaking, though, for a normal, healthy individual with properly functioning kidneys, you really should not see any glucose in their urine. The little amount of glucose that can manage to escape through filtration will eventually be reabsorbed throughout the tubules. So just know that you see a lot of things being reabsorbed, some of which are glucose, also different ions, so sodium, potassium, bicarb, all those things are going to be either filtered or secreted. And then also water is going to be reabsorbed, because you secrete a lot of water at the level of the glomerulus. Right? You're filtering out tons of water. You want to make sure that you try to reabsorb as much of that water as possible. So more than 90% of water is being reabsorbed, thankfully. And then you're also seeing the secretion of different wastes, which we'll talk about later. So I know this says over here in the cortex, but know that the loop of Henle is also dipping down into the medulla. Okay, so the renal medulla, where you have the renal pyramids. So the cortex is mostly going to be these guys over here, glomerulus, proximal convoluted tubule, and the distal convoluted tubule. But know that between those convoluted tubules is going to be this loop of Henle. And we'll discuss what the loop of Henle does later on. So here's another image that kind of shows what's going on in terms of things that are being secreted versus reabsorbed. So everything that's filtrated out of the glomerulus eventually makes its way into the proximal convoluted tubules. Water is going to be heavily reabsorbed at the level of the proximal convoluted tubules. You're also going to get reabsorption of things like sodium, bicarbonate. You're going to get secretion of hydrogen ions taking place over here at the level of the proximal convoluted tubule. Then when you get into the loop of Henle, mostly what's going on is water as well as sodium chloride. That's going to be the reabsorption of water. Then when you get into the distal convoluted tubules, you do get some reabsorption of water, but you're mostly going to be seeing secretion of different ions like potassium and hydrogen. Okay, moving on. We already kind of talked about this, so let me skip that for now. Moving forward. Now, in terms of types of nephrons, you have two major types of nephrons, the most abundant of which are going to be the cortical nephrons. So as the name implies, they're going to be the ones that are a little bit more superficial on the kidney. So it's going to be more abundant within the superficial cortex. 85% of all of your nephrons are going to be these types. And you're also going to find juxtamedullary nephrons. So those are going to be a little bit closer to the renal medulla. Okay, so in other words, you're going to have those glomerulus, proximal, distal convoluted tubules. They're all going to be really close to the medulla, which is where you find the loop of Henle dipping into. Okay. And then in terms of the juxtamedullary nephrons, that's where you find vasorector. So the vasorecta are going to be all these little vessels that are going to be traveling along the entire length of the loop of Henle. And so those are the differences between those two there. Nothing really too crazy. Let's move on. Cool. And let's talk about what's going on at the level of the glomerulus. Now, at the level of the glomerulus, you're going to have a couple different things. You have those capillaries, which are going to be highly fenestrated, right? They have these large openings. Surrounding those capillary beds are going to be podocytes. And so that's going to be these cells over here. The podocytes are going to be cells that kind of project these tiny little feet. That's what podo stands for. It's like little tiny feet. But think about them as being like little finger-like projections that kind of surround the capillary beds so that they can help to control the passage of different solutes in and out of the capillaries. You're also going to find mesangial cells within these regions. Mesangial cells are going to kind of act as like supportive type structures that can help to like dilate or constrict the blood vessels. And then the pedicles are what come off of the podocytes. So, in terms of those structures, you're going to have the visceral epithelium. The visceral epithelium is where you have those podocytes basically kind of surrounding the capillary beds. So that'll be the visceral epithelium. And then you're also going to have those little filtration slits. Those filtration slits are what you have, where you have like movement of different solutes, ions, different compounds. These are going to be highly selective, right? So they're going to be selecting for certain types of filtrate. They're also going to be selecting against things like, for instance, albumin and glucose. So they're going to try to prevent certain solutes from passing through. And this is what it would look like on a scanning electron microscope. So you can see the podocytes that extend out their little projections. And then you see all the little pedicles that kind of like intertwine as if you're like putting your fingers together. And then you have like these little filtration slits between those pedicles that allow for different things to kind of filter out through into the capsule. So as I mentioned, the capillaries are going to be highly fenestrated, meaning that they're going to have a lot of openings, a lot of windows within them. So it's going to allow for tons of materials to pass through. Those are going to be controlled by those mesangial cells. Mesangial cells are going to allow for the constriction or dilation of those capillary beds, depending on what how much filtration you need to take place. So in other words, if you want a lot of filtration to take place, you might get more dilation. If you want less filtration, you might get a little bit more of a constriction, which is going to be controlled by those mesangial cells. So they're actually going to have actin and myosin in them. So it's going to be very similar to like muscle type tissue. And then if you recall when we talked about angiotensin II is going to be a very powerful vasoconstrictor, right? And so if you have the presence of angiotensin II, those are also going to help constrict the mesangial cells to constrict those capillary beds. So this is what that whole entire region looks like. So here's the capillary bed. This is where you have blood coursing through at the bottom over here. There's going to be little pores, right? And those pores are going to be where you see filtrate coming out of the blood. Then you're going to have the basal lamina beyond the capillary. And then once you get into Bowman's space, that's where you find all those podocytes and those like pedicles. So these are all going to be those like foot processes, right? That's coming off of all those podocytes. And it's going to be very selective. So these are like selectively permeable. That's one way to think about it. So it's going to select for different types of solutes, which I'll show you in a second here. So here's another image of what that looks like. So here's your glomerulus. You have your afferent and efferent arterioles coming in. Those the glomerulus, all those vessels are going to be surrounded by podocytes. You're also going to have mesangial cells within all the entire structure, controlling the diameter of the blood vessels. And then you have the squamous cell epithelium that makes up the capsule. And then you have the proximal convoluted tubules. Moving on. So definitely know your three different layers. So the first layer is going to be within the blood vessel, the capillary, is going to be the fenestrated endothelium. Okay, so endothelium, that's going to be within the lumen of the capillary bed. Then beyond that is where you have the lamina densa. That's going to be all basement membrane. And then beyond that is going to be the filtration slits. And this is where you have a selective permeability of different solutes. So I'm going to show you an image of what that looks like in a second here in terms of selectivity. So as I mentioned earlier, that when you have filtration taking place, that's going to be really heavily determined by the overall blood pressure. Just like that video I was showing you just a moment ago where it talked about like the vasoconstriction or the vasodilation of those afferent and efferent arterioles. If downstream from the glomerulus, aka the efferent arterioles, if you have constriction, that's going to cause backflow, right? So remember when we talked about afterload, when we were doing cardiovascular? When we talked about afterload, that was kind of like how much pressure the heart had to push up against. If you had vasoconstriction, that would increase your afterload, right? So that would, in other words, increase the pressure against which the heart had to pump, right? Similar concept here. If you constrict the efferent arterioles, then you're going to create back pressure. And as you create back pressure, that's going to help to increase the amount of filtration coming out of your capillary beds at the level of the glomerulus. Now, the opposite is true. If it dilates, right, that's going to reduce the overall pressure. Something else that can happen if you constrict those afferents, right, then you're going to have less blood entering into the glomerulus. That would also reduce the amount of filtration taking place. So, in other words, this is all going to be extremely passive. It's going to be heavily dictated by overall blood pressure. But there's also going to be oncotic pressures determined by the presence of things like proteins. Here's another image of what that looks like here. Here's the inside of the, that would be within the capillary, right? So this is going to be a transmission electron microscope image. You can see right through all those different cell layers. So this is going to be within the capillary. The fenestra, Those are going to be those little openings for the fenestrated capillary. You have your basement membrane over here, and then beyond that, that's where you have all those podocytes, those little finger-like projections coming off of the podocytes that control the passage of solutes. So another thing that you really shouldn't see in your urine. So you never really should see proteins in your urine unless you're undergoing some sort of renal failure or you have like some serious kidney disease, kidney damage. Another thing that you really shouldn't see in your kidneys or in your urine is blood. So blood is supposed to stay within the capillaries. You do see hematuria with different types of conditions, one of which would be blunt trauma, right? If you had an actual injury, you could see blood in the urine. But there's other conditions that can result in blood in the urine as well. We're not going to go into all those. That's going to be left for your pathology class. But you want to make sure that blood stays within those capillaries. But small items, for instance, sodium, right? It's a really, really small atom. So that's going to easily be able to travel directly across the basement membrane and then past the podocytes into the glomerulus. Okay, moving on. One thing that's interesting about the lamina densa, now that's going to be the basement membrane. The lamina densa is going to be negatively charged. And so with its charge, it's going to help to basically push away other negatively charged items. So for instance, albumin, proteins, a lot of those are going to be carrying a negative charge. So you get repelling of those negatively charged contents. Whereas positively charged ions, for example, are going to easily be able to filter across the membrane. Okay, moving on. We talked about the fenestrated slits. Now, in terms of pickiness, right? So this is when I said it's kind of like selectively permeable. That's not exactly a really accurate term to use, but it's one way to think about it. Now, it's going to be selectively permeable, and in each layer is going to be a little bit more selective than the other. Now, the one that's least picky is going to be within the endothelium, right? So those fenestrated capillaries are not going to be very picky whatsoever. As you get into the basement membrane, that basement membrane is negatively charged. It's going to be a little bit more picky. So it's going to be repelling negatively charged ions. It's going to repel negatively charged proteins. So that's going to be the next pickier. But then the last one, at the level of the podocytes, those are going to be the most selective of them all. So that's going to really help to determine what does indeed get filtered out of the glomerulus. So before we go on, I put together quite a few questions for part one. So let's go ahead and log into quizzes. All right, I'm going to go ahead and hit start. If anyone wasn't able to log in, as usual, just give us your name. All right, good. Very easy question. I'm not even going to talk about it. Let's just move on. All right, awesome. So that is the distal convoluted tubule. So if you see anything beyond, well, actually, let me go to the next question. All right, awesome. Anything, yeah, so anything beyond the loop of Henle is going to be the distal convoluted tubules. Anything before the loop of Henle is going to be proximal convoluted tubules. It seems like you guys got a pretty good bearing on that, which is awesome. Awesome. Pretty basic anatomy, nothing too crazy. All right, so something we didn't talk about yet, which we're going to talk about later. You do see peristaltic contractions taking place at the level of the ureter, not not anywhere else. You only see that taking place at the ureter, so going from the kidney down to the bladder. So you do see peristalsis, and that basically just helps move fluid along more efficiently. Good. Afferent is coming in. Efferent is going to be exiting. So pretty straightforward. Cool. Filtration, absorption. Renal pyramid. That's an interesting consideration. So the renal pyramid, what do you find in the renal pyramid for the most part? Huh? Collecting ducts and loop of Henle. Good, good, good. So it does contain some components of the functional unit. When we talk about the functional unit, we're talking about the nephron. The nephron contains the glomerulus, proximal and distal convoluted tubules, as well as the loop of Henle, and then ultimately the collecting duct at the end. So the nephron's a more accurate answer. All right, good. Most of you guys got that correct. Where do you find microvilli? Huh? The proximal convoluted tubules. That's where you find the majority of your microvilli. You do find them, though, in the other portions. You can find some in the distal convoluted tubules. That's mostly proximal. All right. Most reabsorption takes place, again, proximal convoluted tubule, where you find most of your microvilli. You do see reabsorption in other portions as well, but the bulk of reabsorption takes place at the proximal convoluted tubules. Renal corpuscle, you're not seeing reabsorption. What do you see there? Huh? Filtration, good, yeah. Collecting duct, you're just collecting urine. Distal convoluted tubule, what do you see there for the most part? Secretion, good, awesome. Good. Kind of gave you the answer for the last question there. So yeah, renal corpuscle is where you get filtration. All right. If you retain sodium, remember, water follows solutes. So that's a good segue into the next section here. So let's talk a little bit about osmolarity, okay? So water follows solutes. In terms of your blood fluid, so your osmotic concentration on average is about 300. Okay, so that's going to be 300 milliosmoles. Okay, and the main thing to keep in mind about osmolarity and solutes is you have a colloid osmotic pressure. Okay, we're going to talk about osmotic pressures in a moment. Remember when we talked about blood, when we were talking about the capillary osmotic pressure, what was that determined by? Presence of something? Albumin. Okay, so we're thinking the same type of thing over here as well. We're thinking proteins, which is going to be heavily contributing to the colloid osmotic pressure. So up in this image over here, if you have a semipermeable membrane, if on the right side it is way more concentrated, water is going to follow solute. So water is going to be disproportionately attracted to everything over on the on the right side of that image. So pretty basic fluid dynamics. Another image of what that looks like. Cool. So the main pressures that we're going to be dealing with at the level of the kidneys are going to be hydrostatic pressure, which is going to be heavily determined by blood pressure. I remember if the afferent or efferent arterioles vasodilate versus constrict, that's going to have a huge implication in your hydrostatic pressure. Then the colloid osmotic pressure is going to be determined heavily by the type of solutes. So mostly we're dealing with proteins when it comes to osmotic pressures. These are the four major types of pressure that we're going to be dealing with. The most important is going to be this one over here, glomerular hydrostatic pressure. Glomerular hydrostatic pressure, which is a mouthful, is going to be determined by blood pressure. Okay, that's going to be the main thing determining glomerular hydrostatic pressure. That's going to be this guy right over here. That's going to be pushing from the blood out, so out against the fenestrated capillaries, pushing out into the capsular space. The other pressure that's going to play into this is going to be the glomerular osmotic pressure. Glomerular osmotic pressure, which is going to be determined by the presence of, for example, albumin. That's going to try to bring things back into the blood. Okay, so that's going to be this little guy over here, marked by pi little g. Okay, so pi little g is your glomerular osmotic pressure, and it's trying to push, filtrate back into the blood. Then, at the level of the filtrate, you're going to have capsular hydrostatic pressure. That's going to be the amount of pressure within that capsular space. That's going to be trying to push things also back into the blood. And then you're going to have the capillary osmotic pressure, which would be determined by the presence of proteins. But remember, you're not supposed to have proteins in your filtrate. So technically, that should actually be 0. That should not be a value. But we still include that as part of like this whole entire calculation. So if you wanted to calculate the net filtration pressures, then you would basically take your glomerular hydrostatic pressure over here, add that to your capsular osmotic pressure, which theoretically should be 0, unless you have some sort of renal damage where you have proteins leaking out into the filtrate. You subtract capsular hydrostatic pressure, which is pushing back into the blood, and then you add that to the glomerular osmotic pressure, which would be trying to bring filtrate back into the blood through the presence of things like albumin, for example. So here's a breakdown of all of those different pressures, right? So most important one is going to be this guy right over here. That's going to be your glomerular hydrostatic pressure, mostly determined by your blood pressure, also determined by whether or not your afferent and efferent arterioles are constricting or dilating, okay? So that's going to be heavily involved in your glomerular hydrostatic pressure. Glomerular osmotic pressure, just like when we were talking about your lymphatic system as well as your circulatory system, that's going to be determined by the presence of proteins, especially albumin. That's going to be really important in that. Capillary hydrostatic pressure, that's going to be the pressure from the glomerulus or the Bowman's capsule back into the blood. And then the one that should really be absolutely nil or 0 would be your capsular osmotic pressure. You should not have any proteins in your urine. So in other words, that pressure should be effectively 0. Unless, of course, you have some kind of renal damage where you have proteins leaking out into the filtrate. And I personally think that this is a good place to stop. We can continue here and then the rest of renal next time we meet. Have a awesome Easter and a safe weekend.